Welcome to my presentation on the roles and responsibilities of a registered nurse presented by myself, Bradley Evans. Today's contents will consist of recent changes and impacts on the roles and responsibilities, the roles of the Nursing and Midwifery Council, implications of the Code of Practice, the need for effective communication in a multidisciplinary setting, and the positive limitations and effectiveness on a multidisciplinary approach to nursing. What is nursing? According to the Royal College of Nursing, nursing is the use of clinical judgment in the provision of care to enable people to improve, maintain, or recover health from coping with health problems and achieving the best possible quality of life, whatever the disease or disability, until death. There are 4 fields of nursing: adult, mental health, paediatric children's, and learning disabilities. What is a registered nurse? A registered nurse in the UK is an individual with a formal certification of an approved qualification from a registered provider and is considered in good health and character who will uphold the standards and conduct expected of the regulatory body under the NMC registration. We're going to be looking at 5 categories that have impacted registered nurses' roles and responsibilities from the inception of the NHS. First, we have political, that will be followed by economical, social, and finally technological and scientific advancements. The Patient Charter was a formal document published by Parliament outlining patients' and families' rights and responsibilities regarding the care they received. The original Patient Charter, however, had unrealistic goals, and according to the Health Foundation, the Charter stipulated that patients should be seen within 30 minutes of arrival at an accident emergency department. This would have been as unrealistic in the 1990s as it is today. In addition, it impacted the nurses within the departments by increasing work-related stress in attempting to meet these unrealistic goals. This led to further poor standards of care, boosted waiting times, and it damaged trust to the service. Project 2000 was a scheme introduced by the government to streamline university degree training for new nurses in the 1990s. Activity that was previously seen on an apprenticeship level would now be replaced with equal academic and practical learning over the space of 3 years. Upon completing the course, the student would now be awarded a diploma. This impacted nurses' roles and responsibilities, and more noticeably by reducing the workforce by newly proposed student nurses being supernumerary. This resulted in increased stress and increased duties placed on the current workforce. However, this gave way to the creation of the healthcare assistant, or the HCA role, and this was used to offset a declining workforce and bolster numbers to assist nurses with their responsibilities, albeit at a much less clinical level. In addition, this changed the nurses' roles by allowing them to become mentors and trainers, further diversifying their roles. It also affected how nurses approach care. For example, Coleman in 2021 stated that nurses from Project 2000 were more focused on health promotion than disease management, and they lacked the interpersonal and holistic approach to getting to know their patients. The King's Fund expressed something similar, saying there was an inappropriate balance between theory and practical learning, which was too focused on an acute clinical care level, leading to shortfalls in other areas of nursing. The NHS Improvement Plan of 2004 was a white paper document published by the government to outline Labour's 4-year improvement plan to the NHS. It proposed ways to increase capacity, reduce waiting times, and mitigate overall costs. The government offered services financial incentives to entice the trusts to boost their performance, ultimately deciding how they manage their workforce. The government also outlined plans to enable trusts to outsource medical service contracts to provide for new entries into the primary care market. This was a conservative effort to mitigate costs and create a forced sense of interdepartmental partnerships. This in truth did see improvements, however it caused huge influxes of referrals from GPs and other services who were also given financial incentives to do this. This further stretched the nursing staff by increasing their workload, leading to numerous new responsibilities and restructuring of the departments to meet the rising demands. This affected morale, created work-related stress, and ended up in high staff retention. The Health and Social Care Act of 2012 was legislation enacted to change how the NHS was commissioned, involving clinicians and a new commissioning body. This was an effort to improve accountability and give NHS providers the ability and freedoms to improve their quality of care. This gave nurses the responsibility to put patient-centred care at the forefront of their approach, and this promoted a positive change to nurses and their responsibilities by allowing them to personalise their care and provide a better service to their patients, which was a welcome change in the NMC community. This improved their roles and how they treated and were treated by patients, and this created unprecedented trust in nurses from the managerial standpoint, and it increased relations between the NHS nurses and their patients by being upfront and honest regarding care, treatments, and how they would be received. This led to a more efficient and retainable workforce. The UK's population has been ageing since the inception of the NHS, And according to Thompson of 2015, an estimated 3 million people over 80 live in the UK. This is higher by today's standards. This itself places economic and social constraints on the NHS now, and not just within the NHS. Nurses are treating more frail elderly patients with complex illnesses, and this has impacted their roles and responsibilities in areas of care like social, community, district and hospital backgrounds, causing nurses to now diversify and adapt to increasing training required to help them better understand new illnesses and their treatments. Nurses are expected to adapt to this ever-changing role and growing workload, meaning more responsibilities with a lack of staffing, while still trying to meet social demands and remaining within the constraints of their remit to ensure good patient care. The UK has become increasingly heavier, with its obesity levels rising to 27.8% according to the New World Population Review. The NHS spends millions of pounds training nurses to understand how obesity can cause various health issues, such as high blood pressure, high cholesterol and diabetes. It's meant that the nurse's role has changed with how they treat their patients. With the Eat Well and Better Living campaigns to help educate the broader public on how to simplify lifestyle and nutritional changes, nurses are now required to receive better training in how to work in partnerships with other departments such as dietitians and diabetic nurses. Nurses have had to diversify and adapt to changing social perceptions regarding obesity, as scientific advancements have shown that various psychological, physiological and biological elements can cause obesity. Medical advancements have reshaped the NHS. In Florence Nightingale's nursing era, nursing was considered a vocation, not a profession. Fast forward to 2022, and within the NHS's 74 years of service, it has made monumental scientific and technological advancements from the discovery of cancer to the incorporation of the radiographic imaging like CT and MRI scanners. Nurses are now responsible for the care and more invasive procedures with a much more hands-on approach to their patients' care. Nurses now receive extensive training to conduct their roles competently, and when training in university hospitals, they now have access to fantastic equipment that can provide life signs and instill realistic scenarios they could face within their roles, better preparing them for their future as healthcare professionals. This has positively impacted nurses' roles and responsibilities by giving them comprehensive training and practice that makes them competent and confident in their roles and responsibilities. COVID-19 is the NHS's first global pandemic, and it has showed how underprepared the service was in relation to staffing, resources and training. It's affected the roles and responsibilities of nurses within the service by changing how they were expected to work and how they provided and practiced care. During the pandemic, there were overwhelming admissions that required acute, high dependent and intensive care. A lack of resources meant that nurses had to prioritise staff shortages over equipment. Nurses were hit with staff shortages as those from the EU, Commonwealth and other international countries could no longer bolster numbers due to national and international lockdowns in travel. Nurses were subjected to and infected with COVID-19, and this impacted nurses by increasing their workloads, working longer hours, with increased responsibilities, placing further emotional and mental pressures on an already stretched service. The King's College London research paper released in 2020 found extensive evidence that nurses presented concerning levels of physiological distress, including worrying signs of PTSD, that were directly correlated to their experiences within the pandemic. Nurses took on new roles as counsellors, contact points and chaplains within their own rights. To try and overcome these impacts, the government released emergency legislation allowing recently retired out-of-practice nurses to rejoin a temporary register with the NMC. Overall, having looked at the political, economical, social, scientific and technological impacts on nurses, roles and responsibilities, you can see that they are all related to each other in how they impact nurses. For example, as new white papers or legislation is published, this leads to changes in funding, causing economical impacts be that positive or damaging to the nursing workforce. Social dependence by the public creates demand that cannot be met, leading to extra responsibilities for nurses and a more burnt-out workforce. This shows how recent changes in each setting have impacted the roles and responsibilities on the registered nurse. The NMC. The NMC stands for the Nursing and Midwifery Council. And who are they? The NMC are a combination of lay, non-nursing members and nursing practitioners who work together to ensure that nurses, midwives and health visitors provide high standards of care to their patients and clients. The organisation was established under the Nursing and Midwifery Order of 2001, and they opened for business in April 2002. They superseded the previous governing body, the United Kingdom Central Council. What is their role? The NMC's role is to regulate, support and influence, and they regulate high standard of education and professional standards through the professional duty of candour and their code of practice. They support their professionals and the public through an open register of nurses and midwives, and in 2021 there were over 716,000 nurses registered. How do they support the development of practice? The NMC helped nurses develop their practice by setting the educational standards through direction to universities on what the curriculum should hold and how it should be taught. The NMC also used a process known as revalidation. This is a process that allows the nurse to maintain their registration with the NMC, and it demonstrates the nurse's continued ability to practice safely and effectively, and is a continuous process throughout that nurse's career, and it was introduced in 2016. Revalidation is not an assessment of an individual's fitness to practice, and in order for them to do that, they must meet these prerequisites: 450 hours of practice, 35 hours of continual professional development, 5 pieces of practical feedback that include supervisions and appraisal, 5 written reflective accounts on practical experiences, and a health and character declaration of any new offences and impairments that must be declared. This is a good way to have positive impacts on the nurse by raising awareness and looking at their own practice, becoming self-aware, increasing confidence, and this helps nurses analyse what they do and helps them further reflect and evaluate their roles and responsibilities. Alongside these positive impacts, the revalidation process allows nurses to be made more aware of policy changes. How do they ensure the practitioner is licensed? The NMC keeps a register of all eligible practicing nurses. They ensure that an individual is licensed by keeping a record of their details on this document. This includes their qualifications and an enhanced criminal background check. And employers by law must ensure that a nurse has a valid PIN and is fit to practice in accordance with the NMC Code of Conduct. What is their role in patient safety? The NMC ensure patient safety by setting standards and a code of practice. The code of practice is something we'll discuss in the next slide. This is essential for the code of practice is the professional standards set in order to meet standard public welfare. The NMC Code of Practice is built on the following 4 pillars: prioritise people, practice effectively, preserve safety, and promote professionalism and trust. What are the implications if you do not follow the Code of Practice? Well, the Code of Practice is the underpinning definition of being a nurse and is non-negotiable. Therefore, nurses must practice effectively to ensure the best outcome for their patients. The Code of Practice is there and has set the standards in nursing practice to ensure it is conducted in a way that is fit to serve the public. If someone inherently disobeys or perverts the meaning of the Code of Practice, there will be consequences. And the NMC will investigate allegations against nurses through a fitness to practice panel. These panels consider if a nurse is fit to practice, and the NMC have the right to discipline the accused nurse found to have conducted behaviour counterintuitive to the Code of Practice, and it can be found in the form of sanctions and cautions that remain on the permanent record, conditions of practice orders, stricken from practice and a licence revoked, and in some cases criminal charges can be brought against the accused. However, it is ingrained in the registered nurse's roles and responsibilities to follow the framework stipulated by the NMC governing body. As discussed earlier, the implications impact nursing practice by managing how nurses practice their trade. It affects the registered nurse by ensuring the punishment for not following the Code of Practice is fair but swift and severe. The standards can negatively impact the nurse's career and the affected patient or patients. On the other hand, nurses who follow these standards can positively impact themselves, their careers and their patients by creating trust and bonds that continue to affect them throughout their career. In addition, the Code of Practice impacts how the registered nurse ensures they are compliant and practice safely. Clinical governance, according to the government, is a process through which the NHS organisations are accountable for continually improving the quality of their service and safeguarding high standards of care. This is followed by risk management, clinical audits, continuing professional development, effective evidence-based care, patient and career experience, and staff management. And I just wanted to touch very quickly on the subject, as this has been heavily influenced by the NMC and other organisations, and it instills some of the same codes and practice by involving nurses in the process and enabling them to provide high quality of care. To conclude, it's essential to understand that the NMC are a governing body that promotes a code of practice to safeguard the practicing clinician and the public that use the service. The regulations of practice and standards the NMC set, they are cultivated into the nurses and midwives to instil pride in understanding their roles and responsibilities in protecting their patient and clients they're providing a service to. The implications of not following these standards is severe because they can have damaging consequences to the NMC, the practicing nurse, the patient, and the organisation, bringing them into disrepute. The nurse must ensure they follow the regulatory stipulated by the NMC, and the NMC are accountable for maintaining these standards. There are systems of work in place like the NMC Code of Practice and the NHS's clinical governance that ensure these implications are far and few between, and they instil reasonable confidence and a competent nursing workforce when these rules are followed. What are the benefits of a multidisciplinary team with effective communication? Well, first off, you get good patient-centred care. It reduces cost in relation to time to treat. It increases operating efficiency, improving time from admission to treatment to discharge. It encourages teamwork with an open working approach with internal and external services, and it reduces patient complaints and improves relationships with patients, creating trust with the healthcare services. What is a multidisciplinary team? Well, the NHS works on a model that puts patient-centred care first, and an MDT team was first introduced in the NHS in 1995 and has since undergone extensive remodelling to improve its service. An MDT is a fantastic tool that is the gold standard in patient care, bringing continuity and access to treatments, ultimately improving the patient's outcome. An MDT utilises all the personal professional input a patient will need in their care and aftercare upon discharge. This will include nurses, physio and psychotherapy, occupational health, GPs, social workers, and district care, among other services. It's crucial for effective communication in a multidisciplinary setting, which is achieved by each department focusing on their aspect of practice. There should be an explicit discussion on an approach that considers the patient's wishes with a clinical clear framework agreed upon by all in the MDT meeting on how to best practice creating a treatment plan. Part of making an MDT successful in communication is ensuring the patient is spoken to in a manner that they understand and any clinical jargon explained to ensure they clearly understand the process of their treatment and are agreeable. This may not always be the case if the patient is under a mental health section and has been deemed to lack mental capacity concerning their own care. The appointment of a coordinator responsible for ensuring that the patient's treatment plan is set and met upon discharge provides effective communication with all departments involved. An MDT is also a cost-effective way to manage patients quickly and effectively to help minimise continual readmissions or extensive outpatient appointments. Communication breakdowns can lead to a poor outcome for the patient. For example, it can lead to an incoherent and impersonal treatment plan, leading to adverse effects for the patient, and it can end up costing the service more with continual readmissions and numerous MDT meetings until effective communication can be established between all departments. So, what are the limitations and effectiveness of an MDT? The positives are person-centred care. According to Health England, there is evidence that suggests MDTs have resulted in better outcomes for patients and their families when applying a person-centred approach to the care provided. This has led to a better quality of care and overall patient satisfaction, and this can also help reduce the cost to the service from repeat readmissions and MDT meetings. If there is effective communication, there will be a coherent, implemented person-centred treatment plan. It can improve efficiency. There is also evidence from the Health Education England that suggested improved efficiency from staff due to increased job satisfaction when positive patient results were achieved, enhancing the skill set and ability to work in an interdepartmental partnership, which is shown to conduce to proficiency in the patient's care. Organisation. Health England have also said that MDTs can improve the way the service resources are distributed to the patient with efficiency while still improving patient care quality and improving overall patient satisfaction. Reduce costs. When an MDT meeting provides patients with access to care, they require it to be shown to reduce readmissions from the same illnesses or diseases. This reduces the cost to the service, and these savings can be reallocated to help other services that require extra funding. Limitations. There are always going to be limitations to MDT meetings, and some of them are always time constraints. There are always time pressures involved. Health Education England and R1 have both commented on evidence that stipulates time constraints can have negative impacts on MDT meetings. Once MDTs have concluded, it takes time for all cooperating services to implement the necessary treatments. It also takes time for departments to complete all the required paperwork and can sometimes be a lengthy process delaying the implication of care. This can lead to poor patient outcomes and patient dissatisfaction. This process can also lead to a lack of communication or communication breakdown, resulting in poor performance and an increased cost to service. Limited resources. A lack of funding, depending on the area of care being provided, can lead to challenges in the delivery of the patient's treatment. Health Education England stated that it can be difficult to correctly allocate funding depending on the time within the financial year, which can lead to members of the MDT feeling the trust is not committed to the patient's recovery. This can lead to poor patient satisfaction and loss of trust within the trust and the patient, and frustrations among clinicians. Incorrect documentation can lead to poor communication and less patient-centred care and a more clinical judgment, making it less valued and ultimately becoming disengaging, making it difficult to complete a coherent plan. Overall, it's evidence that multidisciplinary effectiveness is contributable to its patient's ability to effectively communicate, work as a team and produce appropriate care and treatment for England. Health Education England has shown that positive results in areas of patient-centred care lead to improved efficiency with the service provided and show good cooperation for the patient, resulting in a positive patient satisfaction and a reduction to the cost of the service. In conclusion, the effectiveness of multidisciplinary approaches in healthcare can be determined by the concluded result to its patients that either shows a positive or negative outcome. Thank you for listening to my presentation.